Today on the podcast, we had Christina and Dr. Atabeygi from Summit Pacific, which is a rural healthcare clinic group located in Washington. We talked a lot about rural healthcare, what it's like running the clinic, the locations, the challenges, the wins. So hopefully you enjoy. How did you become the leadership dyad of the clinic group?
So I started at Summit about 5 years ago as manager of the urgent care. And not too long after that, we were in need of an associate medical director for the urgent care. And so that's where Dr. Atabeygi, he knew the senior medical director from his residency. So he applied for and was interviewed for that position and got it. So we became dyad partners of the urgent care. And then a few years after that, we opened the second clinic that falls under us, Summit Pacific Health Clinic. So we worked together to stand that clinic up.
And I don't think I've met like a dyad partnership before. Like what is kind of unique about your partnership with the clinic?
Well, I think the general leadership model for the organization is that every sort of clinical service line is led by a dyad leadership. And so one person is more operational or management, and then the other one is the clinical side of it. And so together they can manage any issues that come up that pertain to one or the other. And they're supposed to work closely together. And so we have a lot of dyads. We're not the only one. Different service lines have their own. Some people are part of more than one dyad. Like technically I have two dyads if you want to get technical about it, but Christina and I mainly work together.
And like, how do you guys work together? Like what's a typical day in your partnership?
Typical day is, it's in any rural setting, you have lots of jobs, wear lots of hats. So for Dr. Atabeygi and I, it's really just managing the day-to-day operations of the clinic. He also works as a provider within the clinic. So a lot of it is just us trying to make time together to make sure we have the opportunity to go over if there are any issues we need to address, go over personnel, budget, if there's, say if we need to write some procedures or policies, but really just making time to connect, because as we wear multiple hats, it's really important that we just come together, because we always want to present as a united front and as a shared voice. So it's really important that we're always on the same page.
Do you guys ever have disagreements or?
Yeah, all the time, I think. I don't want to say all the time, but it's not unusual, I think. And either we sit and talk it through and resolve it one way or the other, or a lot of the times, and I think maybe our dyad is maybe a bit unique in this, that we just defer to the other one if it's their area of expertise. And so, and I think underlying that is that we just trust the other one to do it, if that makes sense. And if they're going to say they're going to do something, that they're going to do it, and then I don't have to worry about it. And so that's the biggest thing. And I think the way we look at it is like leading a clinic is one job, and we're just two people doing one job. We're not two people with separate jobs. And that helps kind of get some alignment on it.
I think anyone who works in any business setting will know that having someone who actually does what they'll say they're going to do, it's probably not as common as you might think. So having a partner, it's like, hey, can you do this? And it gets done. It's a good relationship to have. In your day-to-day operations, what's the hardest thing that you have to deal with, would you say?
I'll start. I think in healthcare and in any other business setting, I think the biggest challenge is unclear expectations of like what you're supposed to do and what your deliverables are, what your expectations are. And part of that comes down to communicating effectively and managing expectations and messaging. And so if we don't know like what our strategic goal is for the clinic or the organization, then we can't really do our job in managing the fine details of getting there. And so, if we don't know our strategy, then we can't come up with any tactics to achieve our strategy. I think that's the hardest part, uh, for me at least. And Christina probably has something similar. Or
Yeah, and because I know all healthcare organizations struggle with this, but specifically in a rural setting, we have lack of resources. And so just really getting our staff what they need, our patients what they need with the limited resources that we have can be really challenging because we can't just refer to the next hospital over. It's not that easy in rural settings. There's lots of barriers such as transportation, child care, housing, different things like that. So really just making sure our patients and staff are taken care of with the resources that we do have.
Mm. So we've talked a lot about being rural. This is like a rural operation. What's the difference between like running something in a rural setting versus, in Seattle, for example?
it just comes down to the locally available resources. And so how many hospitals are, in our town? Well, we're the only one. There's other hospitals sort of nearby that are of varying sizes. And if you're in Seattle, you might have 20 specialists down the road you can refer people to. And in our area, we might have one that's in a different city, like 30 or 40 miles away. And, one specialist can't absorb all the traffic that they get sent to. And so we have to figure out ways around it, things we manage ourselves that maybe would otherwise get referred out in other places. And we just kind of do what we can.
Yeah. It's a good moat, though. It's what they always say, like a moat. Like you're there to provide for the people in that rural area, and there's no one else there to, that's kind of your job. What would you say is like the biggest bottleneck in rural health that's really like, is hiring tough, for example, or supply and demand or something?
There's lots of struggles. I'd say one of the biggest one is just access for our patients, especially to primary care. And that's a problem all over the U.S., but especially here when we have fewer providers per capita to provide care. But really, just being able to get those patients in a timely manner, especially for like chronic disease management or preventative care. And so some has been really creative. We do have an urgent care, which is one of the 4 rural health clinics. We also have a same-day clinic where folks can walk in. So that way, if somebody has maybe upper respiratory infection or a rash or something, but they can't get in with their primary care provider for several weeks, at least they can walk into our urgent care or same-day clinic, and that keeps them out of the ED. So some it's been really creative in saying, okay, what resources do we need in the community? Same with specialty services. Some it's been very strategic in thinking, okay, somebody will drive 60 minutes away to get their hip replaced. They're not going to drive 60 minutes away to get their colonoscopy. So what they've done is they've just been really strategic on what specialty services can we bring in-house to improve the lives of our community that they're not willing to travel for.
And I'm a little bit ignorant to this topic, but as far as like hiring doctors, I imagine it's like there's probably not a lot of local, like how does that work for rural hospitals to hire on doctors?
So we have just like any other, there's job postings, and then sometimes we work with recruiting agencies. It's probably more difficult compared to other places, but I wouldn't say it's been overtly difficult. I think there's some subset of physicians who like working in that kind of environment. And also we have a family medicine residency program. And so we train doctors kind of locally, and what we would like to do is kind of retain them afterwards, although for various reasons it's been hard. And so that's a good pipeline, but I don't think it's been too hard. There's always interest. I think people want to work in a smaller system and get away from like the giant healthcare corporations or health systems that kind of make you feel like you're a small cog in a giant machine. And it's just a different kind of environment. And, that aspect of it makes recruiting a lot easier.
Yeah, I think the West Coast as well. I think there's something inherently special about the West Coast, like especially like just the beauty of it. Are you both natives to where you're from, or are you both from out of state?
I'm actually,
Alma.
yeah, I'm from Kansas. I spent 23 years in the Army, so I retired about 45 minutes away from here. When I got out of the military, I just chose to stick around. And then I was familiar with Summit by working at another organization. They're actually one of our partners. And so that's how I ended up at Summit.
And
Yeah, I grew up in Vancouver, Canada.
oh, really?
Yeah, but I did my residency in Olympia, and then just kind of stayed in the area afterwards.
I spent a lot of time on Vancouver Island myself, so
Yeah,
I'm well aware. It's not. It's pretty much looks exactly the same, but probably as
it's
Washington.
it's pretty the
It's
same.
copy paste.
Yeah, not a big adjustment, that's for sure.
And sorry, and then how did you end up then from Vancouver to Alma?
So I did my residency training in Olympia, and then afterwards just stayed in the area working, and then eventually ended up in Elma after a couple other stops.
Awesome. So then with the clinic group and all the different things you're running, and this is kind of more of a question about running healthcare in general. What's the most challenging segment of the operation? Is it like the urgent care or same day?
They each have their individual challenges. And what's nice is we do manage both clinics and they have a similar mission. And so our advantage is we're able to shift resources between the two. But it's hard because we don't have set appointments. We don't know if 20 people are going to show up that day or 60. And if 60 show up, are 30 of them going to show up, within the same 15 minutes? So really just how do we maximize our resources with all the unexpected? We have budgeted visits. We look at previous years, and so we can anticipate how many people are going to see. But like with COVID, it just kind of, changed everything. And so it's really us remaining flexible to meet the needs of our community.
And so then what is Summit Pacific's COVID story? What happened to you during COVID? Because you were both in operations when COVID happened.
Yeah, I came in, I think oh my God, when did I come in? Was it 21 or 22? I can't remember.
I don't, one of those
It was
years.
21. Yeah, it was later in 21. So I missed the first 2 years almost. So I wasn't there for all the beginning chaos. So Christina can tell you about that.
Yeah, it was important for us to really just kind of looking for different trends. So what Summit did is we had a lot of people, excuse me, at that time, people, with different businesses and employers, they weren't sure what to do. So there was a lot of demand for COVID testing. So Summit stood up a COVID testing site to try to keep potentially sick people out of the clinics. Also, we had to shift a lot of resources. So as there were fewer sick visits, like in primary care, because it's hard when you have somebody coming in for their Medicare wellness visit who's maybe 80 years old sitting right next to somebody with COVID. We want to reduce risk to our patients. So a lot of it was shifting resources and coming up with different policies to keep both staff and patients safe. And so we would have people covering in the ED or in our acute care unit that maybe traditionally worked in primary care because that's where the need was. And also Summit was very uniquely positioned to not lay off anybody, which we saw in a lot of different hospitals. And one of the reasons for that is because Summit doesn't offer many elective services. It's all required. So, we weren't doing, elective, if we're not doing elective surgery, we don't need to close down that OR. So really just looking at the resources we have, shifting where the most need was, and then just trying to, keep up with the demand because it was busy and, urgent care was seeing up to 80 patients a day. Primary care was trying to figure out how to still get in their patients that need those preventative screenings and health maintenance. So really it was just everybody coming together to figure out how we can do it the safest.
And were there any mistakes during COVID that you learned from, or was it a pretty smooth process for you?
I don't know if I call them mistakes. There was a lot of growing. For example, at one point we started having people, we hired screeners who would screen for COVID symptoms before allowing people in the buildings. It was trying to identify funding that was available through FEMA and other resources. So I wouldn't call so much mistakes, but there was always a new resource or something different or a new requirement from the state. And so just trying to keep up with all those requirements could be really hard.
Yeah. So you mentioned a lot low barrier care. And I'm curious, like what does that mean? Like to extrapolate on that.
Sorry.
Go ahead.
The barrier we want to remove is the time it takes to access your primary care provider. If I, let's say, get sick tomorrow or fall down or hurt myself or have something come up and I call the clinic and I say, can I get an appointment with my doctor? And they say, oh, sure. They have an opening like 3 weeks from now. That doesn't really help me. And so removing that barrier is our goal. And so that's why we started up the walk-in primary care clinic. And, whether you have an injury or something, or say you can't get into your doctor because of your work schedule, but you haven't had a diabetes visit for like 6 months, 9 months, and you're just really overdue. And so that clinic is open and you can just walk in and have primary care services where you can't necessarily access your own primary care. Or let's say you go to the ER and they say, follow up with your doctor in 2 days. Well, there's no way you're going to get in to see your doctor in 2 days. Then you have a place to go to. We can give you the address and their hours and say, just walk in there and they can see all your records and you can follow up and make sure everything's still okay. And so the big barrier is just timely access, which I think is a problem almost everywhere.
Yeah. And that does sound very low barrier. Fair enough. And that's kind of your mission, I guess, that behind Summit Pacific is to kind of open up care to everyone in the rural community.
Yeah, it is. And just recognizing that for a lot of our folks here, we have problems with homelessness, and the county we work in actually has the highest opioid overdose death rate in the state. So there's a lot of barriers. Transportation, a lot of people are coming from 40 miles away, through rural areas. And so how do we reduce all those barriers and make sure everybody can receive care no matter what their situation is?
Yeah. I kind of wanted to end by asking Dr. Atabeygi about some revenue cycle management, because I heard he's the revenue cycle management guy. Word on the street. So, what is your day to day with insurance look like at the clinic?
So rural health clinics are a little bit special in that they operate with an all-inclusive rate. And so when especially for Medicare and Medicaid, and so when someone comes for a visit, no matter what service you provide them in the clinic, you get it paid a set rate. And so it could be a 5-minute visit or a 55-minute visit, and what you get reimbursed for that visit is the same. And if it's private insurance, it's still traditional sort of evaluation management billing, and a lot of our patients are Medicare and Medicaid, and so we work on this all-inclusive rate model where the amount of service you provide doesn't so much dictate your revenue as much as like how many patients you see in a day. And so I think it changes the incentives a little bit. You don't worry as much about, am I like coding every single thing correctly? Mm-hmm. You still should, obviously, for just completeness, but it's not on the top of your mind all the time. And we still, I think, work with our coding team to make sure everything's done properly. But the all-inclusive rate and it's different for every rural health clinic because it's based on their cost report. And so one clinic might get paid, let's say, $200 a visit, and the other clinic gets paid, $350. And our newest clinic might be much lower, like $100 a visit. And so those are budgetary things you have to think about. How's the clinic volume and the reimbursement affecting your operations and your overhead and all that? It's a little bit different mindset when it comes to thinking more about volume rather than the specific services you're giving every single person.
Yeah,
But
I didn't know
dealing
that.
with dealing with insurance, I haven't met a single person anywhere who likes dealing with insurance. And the biggest, I think, point of friction and burnout for all doctors and PAs and nurse practitioners everywhere is the amount of admin work it takes to deal with insurance companies and calling them and being on hold and sending papers back and forth for even the simplest things. And it's turning into like the defining struggle of healthcare almost.
Yeah. Well, it's a catch-22 because you probably have a lot of staff that deal with insurance. You probably have, decently large salaries. So it kind of is a loop where there's insurance paying you to pay the people to get paid by the insurance.
Yeah.
Cycles around. And I mentioned before when we kind of were briefly chatting, at Caesar Health, this is one of the things we want to do. We want to get AI involved in revenue cycle management to see if we can make it more efficient. We're still in a theoretical state, but hopefully we can kind of increase the efficiency and pump out more claims, ideally. That being said, then sorry, Dr. Atabeygi.
I was going to say probably the biggest opportunity in day-to-day on-the-ground healthcare is removing any amount of friction when it comes to that kind of admin work. Because everything else, people are stressed or getting burned out, and it's not like every doctor wants to just treat their patients and take care of them. And then the mountain of admin work that adds up behind that is what's driving people to work less or get burned out or quit. And then it's just this perpetual cycle of, you work like 0.75 of an FTE, but it feels like it's still full time. And so you reduce your hours just to take the load off, which just makes access worse. And then everything kind of spirals from there. So that's the biggest opportunity when it comes to AI or in healthcare is just remove even the slightest amount of friction and it'll get traction.
And I was talking to I tell this story all the time, but I was talking to like an old school doctor. And I said, yeah, we're going to have AI in revenue cycle management. It's going to be able to increase your claims getting accepted. And he's like, oh, I don't know about that. And I just thought to myself, if I went to United and I said, I have an AI tool, it's going to increase your denials by 20%, they would be like, I'm in, let's go. Like they would 100% want it. So I feel like we are lagging behind, which is kind of the point of the Caesar Health project that we're working on.
Yeah. I think it's hard if you don't understand how it works how the system actually works in the background. Like what is AI and what does it do? And if you could get a good understanding of that, I think people would embrace it more.
Yeah. 100%.
And as payers start to use AI more and more to evaluate claims, I think it's important for the clinical staff to keep up with that because we don't want to, be left behind as payers continue to grow their AI and can get through claims faster.
We'll talk after the podcast. No, I'm joking.
Yeah. At some point, it'll just be insurance AI talking to the hospital AI, and they'll just kind of fight it out in the background and figure it out.
It'll just be so much AI infrastructure that they'll just argue amongst AIs. Yeah, it's crazy. We have a Claude bot in the office now. It's hilarious.
You do?
Yeah, we do. We made a video as a joke today. I can send it to you after if you want. It's kind of a joke video where my colleague is like screaming at it, smashing at it, and I'm like, hey man, chill out. And I light a cigarette and tape it to it. It's smoke. It's taking like a smoke break. I wanted to end this. We're kind of at time, but like, what's the future look like for the clinic and for rural healthcare?
Well, at Summit, we just keep expanding. We've added podiatry and GI and sleep. We're looking at adding occupational health, expanding those services. So really for us here, we might be rural and we may be small, but we're always looking for more ways to support our community and meet their needs. So just the hospital just recently expanded and it doubled its hospital space. We're just finishing up that project. So for us, it's just continuing to grow and kind of wherever our community takes us, that's where we'll go.
And what about you, Dr. Atabeygi?
I think growth is our focus, but also sustainable growth is our focus. If we kind of overextend ourselves, then it's not going to be good in the long run. And so far, it's been fine. It's been really strategic about what services we've picked to expand. There's probably more we could add, but it might be nice to slow down for a little bit. And I think a lot of our projects now are focused internally on the things I was talking about when it comes to reducing admin work or removing kind of that day-to-day friction that people come across when they're just trying to get through their day seeing their patients. And it's not like it's in a way it's thankless work. Like what work are you working on? Oh, I'm reducing how many forms you have to sign every day. It doesn't sound as cool as, oh, I'm building a new surgery center or something. But in the long run, I think it's going to have a bigger impact than anything else if we can get it done right.
Awesome. Well, thank you so much for coming on, and it was a pleasure.
Yeah, it was great. Thanks
All
for
right,
having me on.